Hello Thrive Nation, I've got one of my most incredible guests on the show today because Dr. Sindeep Bhana is a health pioneer, he's a health legend, he's trained thousands, I think, of doctors, specialists. He's an endocrinologist that personally I've used over the years, my wife, my family. He's the head of endocrinology at Baragwanath Hospital. He's the founder and director of the Center for Advanced Medicine. Welcome to the show, Dr. Bhana.
Thank you.
Now, Dr. Barney is someone that I'm going to just entrust in terms of speaking about thyroid health, in terms about metabolic functioning, in terms about endocrinology, because I think there's a huge gap in functional medicine. So we're going to start there with a little bit of a background of Dr. Barney's life in terms of his training, why he thinks functional medicine is so important. And then we're going to get into the weeds of thyroid function and hydrogen peroxide and these radical, amazing treatments that he's been doing for many, many years. He looks far younger than he really is. But welcome. Tell us about your history on functional medicine, when things changed from traditional Western medicine to looking at root causes.
So it wasn't so much a change, having brought up in an Eastern philosophy.
Yes.
And you've tasted that as well. I think the guys in the East do it right. The day you're born, the health practitioner gets paid a stipend. Yeah. The day you get sick, the family stops paying the stipend, and henceforth the health practitioner needs to take care of you. So I think it's a nice setup in the sense that we're already talking preventative medicine.
Good.
Western medicine, very advanced, that's the father of modern medicine over there. Patient of that gave me a gift a long time ago.
Yeah.
And a lot of it is quick cure, not always reflecting on working on the cause. And so the need to blend the two was always important and almost instinctive. So way back, I think we started with the first functional medicine practice in South Africa. We started it in 2003 when we were in Melrose Arch. And, at the time I thought South Africa wasn't ready for it. My interest was always in the field of endocrinology because I believe the hormones are what makes one organ talk to the other. In the past, as a student, I always thought it was the nervous system, but that's just the conduit, you see. So neurotransmitters, hormones, I realized were the way the body was communicating. And it's where I wanted to get in. I know if my students had to hear this, they'll think, what? But from an Eastern perspective, I don't think it's by chance that every endocrine organ is aligned to one of those energy centers that we always talk about.
Absolutely.
And so from that perspective, my interest was always in endocrinology. And I've never regretted it because with my background before doing medicine, I did a BSc in genetics and physiology, and genetics was still in its infancy in the mid-80s. And then I did animal and human physiology. So the curiosity was always there in terms of asking why. Why did it happen? Could it have gone differently? And so when I got into medicine, then it was a natural tendency to always stick to the physiology part of it.
But it's not only curiosity, Dr. Barney, you need courage. Because courage is looking at root cause disease, looking at functional medicine. It's still very, not unknown, but it's not sort of well adopted by many medical doctors in terms of looking at all these different hormones and looking at neurotransmitters like serotonin and, looking at all these functional medicine tests. It hasn't been well adopted, I don't think, in this country. So you had to have courage to make a stand and say, we're going to look at root causes. And there are many endocrinologists that don't think the same as you.
So I think modern medicine is being forced to change how they look at things. You're right. Initially, one needed to be brave to be in this field. I do remember one of my seniors calling me in years ago and said, I've had a complaint. I heard you doing ultra-sensitive CRPs on people. Now this goes back to 2004.
Yeah.
But as you know, now it's one of the major indicators.
Sure.
Helps with the determining what's happening with the low-grade inflammation, speaks to what's happening to LDL particles, speaks to Type 2 diabetes is a condition of low-grade inflammation. A lot of the chronic conditions, you know. And so, I think, again, I don't think it was bravery. I think it was having a background of physiology and genetics and the need to understand the why. And some things were obvious. Of course, modern medicine won the placebo-controlled 10,000 patient trial. And some things are just about normal physiology. And that pattern is repeated in every species in the animal kingdom. And so the experiment's done because it's a 200 million year model.
Okay, but don't you think that Western medicine is very good at, from an emergency care perspective? You have a car accident, you're bleeding, now you go for surgery. But now Western medicine is treating chronic conditions by not changing lifestyle, not changing nutrition, purpose, community, those things, social integration, social ties, and then just slapping on some Western medicine drugs, thinking it's going to treat and cure the chronic disease, but it often doesn't.
And so I think you're right. I mean, what Western medicine offers in trauma, unparalleled. Quick fix, it's there. And I think that's where, from a chronic condition perspective, things are being unraveled. It's a twofold problem. The one is, in the last 30, 40 years, the patient has demanded quick fix. I've got an infection, my throat is sore, I want an antibiotic. Well, it's a viral infection. It's not going to really help. But the patient demands a quick fix as well, you see? And the doctor has become siloed. The old-fashioned doctor that made house calls, that knew your family, indirectly knew your genetics, indirectly knew what kind of medicine will work for you as opposed to that particular person. Sometimes a slow approach, sometimes a quick response, because they know the personality type, they know what's happening in the family. They've been treating the family for 3 generations. So indirectly, whether genetics was known or not,
you had a good idea.
That doctor intuitively already knew how that family was wired, you see. And now, I only treat thyroid. You only treat the heart. That person only treats the lung. This person only treats the rheumatological system. And, you know, I think the beauty of modern medicine is that you can see, we started from a point where 130 years ago we said, well, it's obvious. Let's just break this thing down. Let's take it to the smallest Lego piece, and then I'm going to understand this. Well, quantum physics tells you otherwise, because now the observer is changing
the result.
The result. And so we need to say, okay, no, the biology of the system is such that it's a web. You touch something here, there's a vibration here. You touch something here, there's a vibration here. So you have to look at the entity. And I believe the forefront in the future comes back to the gut. Comes back to where this man 2,000 years ago say all pathology starts in the gut. And that is what's going to have to unify us. Because let's just take autoimmune conditions, right? I mean, there's a few in the field of endocrinology. So we're sitting with a problem. We know it's an autoimmune condition. We know there's a crosstalk between the antigen and the antibody. And guess who makes the antibody? The self. And so there's a predisposition from a genetic perspective, but not every patient's getting it. And it's not following the Mendelian genetic pattern. And so now it seems that the gut is the second hit. Well, then is there any difference between multiple sclerosis and rheumatoid arthritis and Hashimoto's and alopecia and psoriasis? We're giving it different names.
That's just the external manifestation.
Exactly, because it's a different antibody. But when you start working on the gut, then things may turn differently. And you can see the race is on. The pharmaceutical companies are patenting different combinations. And 3 years ago, if we had a conversation like this, it would be a swear word in modern medicine. But in the last 6 months, there's a pharmaceutical company that registered a combination of a probiotic with a combination of different bugs that drops the HbA1c by 1 percentage point.
Wow, that's incredible. We'll get into the weeds in that.
Yeah.
But do you know that what Hippocrates said was the greatest medicine of all? Do you know what he said? Is to teach people how not to need it. And that is greater than the microbiome, that is greater than the gut, is to teach people, because the word doctor comes from the root docere, which means teacher. And that's why I hold you in such high regard. Why? Because you've taught so many doctors, you've taught your patients. So tell us about the next frontier of teaching, because like we were speaking earlier about the chasm between the specialist and the doctor. There's not enough doctors to see these patients. So in between is a chasm where we have health coaches, change agents, people that can help and journey with patients and teach them and show them. Because at the end of the day, you've only got half an hour of a consult to a certain degree. Now, how do we bring sustained transformation? Tell us about the new teaching frontier.
You know, your question takes me to a conversation I had years ago with a good friend of mine, Dr. Mutara. We were sitting, I think, 2003, 2004, and both of us Western trained, him a cardiologist, and I was talking to him about the importance of functional medicine in the field of cardiology. Of course, it was a hard pill to swallow at the time, and understandably so.
Yeah, sure.
Yeah, and we were chatting, and after a while, he started seeing what the nexus was about. And then he sat me down and he said, Sandeep, this is not good enough. We're treating one patient every half an hour. How do we take that to the masses? And in my naivety, and I said, well, I don't think we can, because endocrinology and functional medicine is such that it's individualized. So there isn't a protocol. There isn't a one size fits all. And you know, kudos to him. Look what he's doing now.
Yeah. No, it's great.
Because he said, no, there must be a way. Well, almost 20 years down the line, he's found a way to take it to the masses. Yeah. And that's where you come in, because actually, I think the patient, the participant, the partner, who's the patient in this, has got access to this now.
Yeah.
And so whether we like it or not, whether we tell them to Google things or not, they are already empowering themselves. So when they come half empowered or 3/4 empowered or 90% empowered, they just come in to confirm a few things here. And so they realize that they are part of this journey. And my philosophy was always, and it was also selfish, is you've seen when your partner came over here, I discuss the results, I give them the options. Indirectly, I'm a coward, because indirectly, I'm passing the buck on to them. I've always told all my students, as long as you hold the power, healing doesn't take place. As long as you've transferred the knowledge onto your patient and you've given them the options and they've made a choice, they've taken on the responsibility of getting this condition right. And that's how you get the glucose control right. That's how you get the buy-in on the cholesterol. That's how you get in the buy-in on the blood pressure. That's how you get in the buy-in on the tough one, which is changing lifestyle.
Yeah.
And I think it's an important journey. For me, it's become a bit easier to sell it to my patients, because a lot of the things we deal with has a genetic component to it. And I said, you're not doing it for yourself. You're doing it for the next generation, because they're going to see you do it. And the child benefits, because it becomes second nature to the child. The child then doesn't look at it as I'm being punished by Bhana or by Stavro because I'm not allowed to do X, Y, and Z. It's not about not allowing. There's no not allowing. There's balance. You know, all of us got a bit of a devil.
Sure, but are you seeing that with your type of patients here? Because what I see, if you look at the big data, the last 3 years in the CDC in America, longevity has come down. You're looking at 88% of the American population that's considered unhealthy. Only 12% have metabolic health. It seems like we're still on the way down with regards to our health. Or is it those that are only educated, that have finances, that are saying, okay, I'm going to do functional medicine. I'm going to do these audits. I'm going to do those audits. I'm going to change my life. I'm going to eat organic. I'm going to do breath work. I'm going to do mindfulness. I'm going to go to the yoga studio. I'm going to go walking. what's going to happen that it's going to translate to the general population? Because what I see is people are getting sicker and sicker. And we see that with the pandemic, because the biggest reasons that why people have got really sick and have died is because they've had poor metabolic health. Yes, there's age. That is something that plays a huge role with your immune system. But the biggest reason is metabolic health.
Do you know the difficult answer there is you have to see the abyss before the change happens. And so when you're talking about lifespan, let's go 1920, let's go 1940. The average age was much lower. Then it started climbing.
Sure.
And we attributed that to modern medicine, to penicillin, to better eating. And many things happen over a period of the next 30, 40, 50 years for there to be this climb in the Japanese average age, what was happening in America, what was happening in Europe, what was happening in Finland was different to France, and so forth. And you're right. And now the age is starting to come down, because the things that caused age to be lower then was infectious diseases.
Yeah, exactly. Wasn't chronic diseases.
And maternal health and the mortality rate in the first 5 years.
Yeah.
And so we see an improvement because there's more people coming into the system, and when they're in the system, they're living a bit longer. But now we've seen the result of that means more metabolic conditions. Once you start living longer, you start seeing the metabolic effect. The perfect example is actually in endocrinology. Type 1 diabetes. 19th century. You got type 1 diabetes, you're dead. In the next 2, 3, 4 days, it's unfortunate, but this child has been died.
Yeah.
Okay. Unless the mother follows what the Mayo Clinic told her and said, ketogenic diet. No carbs, and your kid's going to survive. And they survive. Thin, puny, but they survive. Most pass on. And then there's a miracle drug, insulin. And so, wow, the kid survives. Kid can eat whatever they want to. And we think, there, we found the cure and we sorted. 15 years down the line, 20 years down the line, what happens to the child? They survived. But now, they've got microvascular complications, macrovascular complications. They've got neuropathy. They're becoming blind. So you're starting to see that it's not as easy as just keeping the glucose at 10, that there's this fine-tuned system in your body that's demanding more from the healthcare practitioner. And so you say, we're going to go lower. And 50 years down the line, we go lower, and we see, we're pushing, or we're kicking the can forward in terms of delaying microvascular complications. Not really winning with macrovascular complications. And we said, everything is about glucose. And then you realize, hold on. It's not only about glucose. This is a metabolic condition. Maybe we named it the wrong thing. Maybe this is not diabetes. We should have just called it a metabolic condition because we took our eye off the blood pressure, the cholesterol, the weight. And now, 20, 30 years later, we realize, it's actually about inflammation as well. And so that journey took 100 years. You see, patient was dying in 3 days, survived, ended up passing on with something else needed to happen, and then we changed. We see it with HIV. Person's dead, 3 months, 6 months, 3 years. If you don't treat HIV, they die of something else. You treat HIV, you think you're fine. What happens 5 years down the line? Metabolic. They got dyslipidemia, lipodystrophy, diabetes, blood pressure. And so, unfortunately, I know I've given you a long answer. Is you saying, what is going to change? We need to see the bottom. And when you see the bottom, you realize there must be more. There's actually a very nice Sanskrit word for that. It's called vairagya, dispassion. You have to bottom out, and then you say, there must be more. There must be something else to this. And that is what I tell all my students. is I remember being a student, I said, oh God, everything's been invented, everything's been done for, is there any space for us? And I'm telling them, I'm saying endocrinology, immunology is still at its infancy. There is still so much out there. And as long as you're curious and as long as you're going to be asking the question why, things will unfold. And the patients are asking that.
Yeah. Well, the patients aren't they saying about antibiotics, the double-edged sort of antibiotics, this can save your life? And then repeated use of antibiotics, what does it do to the microbiome? The oral microbiome, the gut microbiome.
And it took us 30, 40 years to realize what we were doing on the other end. Quick fix, good. Patient survive. But in the long term, it's messed us up. I mean, I'm still waiting to find my gynecologist of his offspring. Because my mother's gynecologist said, don't give him breast milk, give him cow's milk. The rest is history. Obviously, I've got major allergies, and I can tell you how my life unfolded, but it's about the gut microbiome at the end of the day. Yeah, and it had an impact from a physiological perspective, endocrine perspective, and you know the journey.
Sure. Let's dive into thyroid health. I know that's been an area of specialty for you for a long time, and I think in 1979, 1% of thyroid patients had Hashimoto's thyroiditis. I think now it's over 90%. It's a real problem. Thyroid health is a real issue. Let's talk about TSH. Let's talk about T4, T3, reverse T3. Even looking at a ratio, I was speaking to Dr. Levy, Dr. Thomas Levy, the cardiologist, looking at your T3 to reverse T3 ratio, how important that is from an oxidative stress. Take us through what's happening with the thyroid. Why has it been so dramatically affected in modern living, and those numbers, and what people should do about it?
So I've just written the paper. It's about to be published. So we now know the prevalence of Hashimoto's in South Africa. We've always assumed what was in America is going to happen here, what's going to happen in Europe here. But we know from the Indian study, the Korean study, the American study, and the English study that the prevalence is a bit different, right? Okay. And so, of course, in South Africa, we're sitting with unique population genetics. Right? So the Americans, when they study their African Americans, that's a West African gene. Ours is a Southern African gene. So completely different. And also, we're unique in South Africa in the sense that we've got people from all over the world. And so this mixed potpourri is always going to have a different expression from an autoimmune perspective. Yeah. So the number has been growing from an autoimmune perspective. We see it with type 1 diabetes. As we move away from the equator, the incidence is increasing, prevalence is increasing. We see as people move from rural settings coming into the cities, autoimmune conditions are increasing. So why would it be different to thyroid? And so that's why we've seen an increase, not only in Hashimoto's, but also in Graves', the opposite, overactive thyroid, right? And so, yes, Hashimoto's is on the increase. I think the gut microbiome is contributing towards the increase as well. You wanted to know what's the crosstalk in terms of TSH, T4, T3, reverse T3.
You know, I mean, traditional doctors, and the reason I say this, they'll do a TSH, they'll do a T4, they'll leave it at that. You know, and then the patient
will have... So we've got the funders to blame for that, right? So traditionally, go back, third year physiology, they taught you T4, T3, TSH, deiodinases. There was reverse T3. The profs in the 70s were measuring reverse T3. In the 80s, then it went away. So the beauty of the endocrine system is such that there's always a feedback system.
Sure.
There's always a check and balance in the system. Tells you how important the system is, because if you got a second check in balance situation, it tells you from an evolutionary perspective, this was very much needed. And so the gland, the thyroid gland, is a small butterfly-shaped gland sitting in the neck and controls the entire body's metabolism. And it does so by producing a hormone called T4. And then T4 converts to T3, which is the more active hormone. Thyroid gland makes about 10% of the T3, but most of the T4 production is peripherally in the other organs. Now we know that the liver is making a different amount than the pituitary, which is making a different amount than the gut. And it's making a different amount than the ovary would. Okay, so something needs to regulate that. So we thought everything is regulated by TSH. But how come TSH is talking differently to the liver and the ovaries and the testes? So therein comes those enzymes, the deiodinases. Because the deiodinases, deiodinase 1, 2, and 3, speaks to what needs to happen from T4 to T3. And if the T3 is going up too much, how can it be stored elsewhere? There's something called reverse T3. And what shifts it back? And so all of these systems were always there. We just didn't understand them too well. And so if you look to the animal kingdom, they play a role in hibernation. They play a role when there's famine. And so it's no different in us as well. And so the role is unfolding. And there's a few studies now showing that there are people that are T3 deficient. And the first study showed that it was around 26% of patients who had an underactive thyroid didn't convert T4 to T3 as well as we'd like them to. There's another study that showed about 13%. In about a year and a half, we'll publish our data. That's the third paper from my PhD. And we look at the prevalence in our society. But it does exist. Now, that is just genetically speaking, we're saying X amount of patients will not convert T4 to T3 efficiently. However, it's more dynamic system. Because out there, the polar bear, physiology is a bit more sophisticated. It knows how to change that. Okay? And so it's wired at a different level, but that's where reverse T3 comes in. It's actually a natural dump. When there's trouble, when a patient's got cardiac failure, when there's a systemic condition, when there's a chronic inflammatory condition, the body knows it needs to down-regulate the T3 because the organism needs to survive. And so it dumps it into reverse T3. And that's why that enzyme process is dynamic. So yes, genetics play a role, but epigenetics play a role as well. And we know that once the patient comes out of the chronic condition and they get a bit better, that the system starts reversing a bit. And we know that from a condition called sick euthyroid syndrome. So the problem is the medical aid tells us, we must only do a TSH. And when the TSH is up, then we know there's a problem, probably with an underactive thyroid. And when it's suppressed, it's probably an overactive thyroid. Then check the T4 levels. So we check the T4 levels and we confirm it's an overactive or an underactive thyroid, and then we act on it. And except for endocrinologists, not many people are allowed to do a T3. It's too expensive. Leave alone reverse T3. Okay. And so cost does play a role.
What about the patient out there who's got a TSH sitting at 3.2, the range is too big, the doctor's not checking T3, reverse T3, they've got these problems. It seems like it's becoming more prevalent in modern society that we've got this thyroid dysfunction. With age, it becomes more dysfunctional. Surely these should be just standard stock tests for people to say, here's the option. We can do a full thyroid panel, thyroid antibodies, everything included, so we can find out, because it's so important in the body.
So I think the option is always there. The problem is the payer has become a businessman. And so therein lies the first trap we all set ourselves, is that the doctor and the patient made a mistake by allowing a third person to come in. The insurance industry.
That's for fun. Tell us
right?
more.
It stems out of fear. And so as soon as the third person comes in, they're holding the funds and they say, don't worry, we'll give you the money when you need it. And so initially in the insurance game, Bhana could easily treat Stavro. I said, I need X, Y, and Z. Sure, go for it to be fine. But as the numbers start growing, they'll say, no, Bhana, you're doing too many of these tests. You need to cut it down. No. He's my patient. I will do what I like. However, the shift in power has gone to the funder now, because the funder now holds the book and determines who goes where. And so the patient will now go to somebody that the medical aid says go to X, Y, and Z. And X, Y, and Z is now limited in what they can do. Next step, the funder tells me, hold on, you can't use this treatment. You can only use that treatment. Gone is the 2,000-year-old transaction we had, where the doctor the apothecary actually mixed the medication, worked out what was needed for the patient, gave it to the patient, followed the patient up to see if things got better. Now somebody else is making the medication. So the right arm may not be talking to the left arm. And so I'm managing this patient, but I'm hoping for somebody else to come up with the cure. When somebody else comes up with a cure, this guy is controlling what I use, when I use, and how I use it. The person you're talking about always had the option of any test they want. They just have to pay for it. The interpreter is always there. And therein lies the problem. Because now the person, the patient, the partner's expecting the other party to pay for something that they want, but they're reluctant. The doctor is getting in between all of this. And so, you're right. All three of us are at blame.
Yeah, but give us hope, Dr. Bhana here. What's going to happen with regards to functional medicine? Because I just see that we've got to teach people, to empower them to say, hang on, I'm not feeling well. I'm just not happy with what's happening. I've done blood tests.
Here's functional medicine. Unfortunately, at the moment, functional medicine is growing off its own back. And most of the patients are having to be out of pocket, right? But let me give you a classic example. Well-known politician in this country came to me a few years ago. He told me I can mention his name, but I'm not going to. He said, I'm going to come and talk to your students because they need to be thinking differently. He came to me this big. At the behest of his wife, who's also a politician, begging him for 3 years to come and see me. HbA1c, which is a measure of sugar, 3-month average, 12.8, on over 100 units of insulin. He's on a statin. He's on an antihypertensive, more than one. He's on gout medication, and he's on baby aspirin. That's him. Let's fast forward. Now, he's got my waist, no insulin, HbA1c 5.6, no blood pressure medication, no statins, no gout medication, no aspirin.
What happened?
Functional medicine happened. And you said, can a doctor alone do it? No. The doctor was one cog. The patient bought into the idea of this is reversible. How do I make it happen? And so took responsibility, changed lifestyle, changed eating, got a biokineticist involved in the beginning. And so all the other parts matter because the doctor's got 7 minutes if they're GPs, specialists 20 to 40 minutes, and then the patient's on this journey and somebody needs to help that patient along. There's a magazine there with a patient of mine, well-known nutritionist, Nikki Kotkas, years ago came to me, 88 kilos, enthusiastic, wanting to, you must interview her one day. Very interesting.
Good.
Practice. And she speaks the other part of functional medicine, changing the patient's lifestyle, empowering the patient, teaching the patient how to go about doing things. And her journey, well, from 88 went down to 52. Journey of thyroid. Now, no change in thyroid medication is going to get a patient from 88 to 52. Something else needs to happen.
Yeah, sure.
Normally, you got a 5 or 8 kilo gap with thyroid. Something else, because thyroid affects the other parts of the physiology as well. One needs to understand that the role of insulin resistance, the role of fatty liver is emerging now. We spoke about it in 2003. Inflammation, pituitary, adrenal, very important. And so one needs to manage all of this. So that's the hope you're looking for, because there are these champions out there that have changed it. I had a patient 200 kilos. My prof said, you need to see so. This was my mentor. And I'm thinking, how do I tell my prof? I mean, what do I do? You can't tell your mentor no. But 2 years down the line, that patient was 112.5 kilos. Almost 88 kilogram loss.
Sure.
That was before the GLPs came onto the market. So there has to be, like anything in life, you need two hands to clap.
Yeah.
So you need a willing healthcare practitioner who's willing to see you through this journey, and that there isn't just silo medicine. The partner needs to buy in and realize that it took them 30 years to get here. It's not going to take 3 months to reverse this condition. And, that's the journey. And the same politician I'm talking about, took his wife 3 years to get him there. He's reversed everything. She's still where she is.
Sure.
And so, same family, same dinner table.
With the personal accountability, valuing your health, that priority of value, which is really, really important, which people don't, because then people will take their money and their resources if they value their health and they'll put it in that, rather than actually go to the functional medicine doctor, get the supplements, change their lifestyle, rather than buy the latest Bentley or BMW.
And for this person, it was an expensive journey. But now, in retrospect, he reckons it's the cheapest journey he's ever had. And so what has he done? I've seen all three of the kids early, because he said, listen, I don't want them to be where I am later. Start looking at their physiology now and guide them. And so that was quick, because it was easy for them to see their father's life journey change. And for them, they didn't need convincing, because they saw the numbers, they see the genetics, they say, right, I don't want to be where my father was. Let me take the shortcut.
Okay.
And so now it turned out to be the cheapest investment he's ever made. And it happens to be the cheapest investment on behalf of the funder, because the funder was going to be paying for insulin, for antihypertensive medications, and for the last 5 or 6 years, he hasn't been on any of this. So who's gained the most? The patient and the insurance company. And so the funders in the future are going to have to look at things a bit differently.
Good.
They're going to have to look at it differently. Unfortunately, nobody can force the hand except for the client. And who's the client? It's not the doctor. It's the patient. The patient belongs to the funder. The funder belongs to the patient. I've become the third party. You've become the third party. And so, is that my battle? Is that your battle? It's not going to be a battle that's going to be fought by one person.
Yeah, it's our battle, isn't it?
It's our battle, all of our battle. And we're going to have that battle for the next generation.
Yeah, it's true. I do, I've asked Dr. Golding, Dr. Matara has been on the show, which has been fascinating. Dr. Levy, many doctors, 75 episodes now. And I always ask them their 10 most top important blood tests. If you have just 10 blood tests to do, cost is, something that people have to consider. If people are going to go with 10 blood tests, they're going to go to their doctor and say, listen, these are the 10 blood tests. They might not want to be even thinking about, red cell magnesium levels, or a ferritin level, or homocysteine level, or HSCRP. What are your top 10 blood tests that someone's listening now and saying, okay, I've had a thyroid issue, or my doctor says my thyroid's fine and my TSH is sitting at 3.2, but where do I go? What do I do? What are the top? Where must I educate myself with my blood test?
Steve, you're killing me here. So, because I started off by saying, mine is a very individual game. I have a set of twins who will have similar thumbprints, and yet their bloods are completely different, right? And so it's very individualized, because we've got patients from all over the world, except South America, right? And they'll say, no, let me just do the test and then come and see you. It will save me a trip. And I said, but it doesn't work that way. Because the list of blood tests is this long.
No, sure.
Individual. But I hear you. So in my mind, I say, let's go back to physiology.
Okay.
Let's take the studies and science out of it a bit. Because life's been around on this planet for 4.3 billion years. Okay? I've been around for 54. So the knowledge lies in that reservoir. So what is aging? Aging is a balance. Yes, genetics play a role, but it's a balance between free radicals and antioxidants. And it's the repair system. And so that must be important. So let's take a step back and say, well, what's my best reflection of my antioxidant state? It has to be homocysteine. So modern medicine has picked up on that, but they look at it at its extreme, that when the homocysteine is 80, this person's going to get a heart attack or stroke. And then the Framingham study says, well, if the homocysteine is 12.4, you're 4 times more likely. If it's over 9.1, you're 3 times more likely. If it's between 6 and 9, 2 times more likely. If it's below 6, the risk is gone. Well, what happens to be the reference range? 12.4. So we're willing to live with 3 times the risk.
Okay, I want to stop you there, Doc. Why don't medical doctors know this? Why isn't out there a simple test of homocysteine?
No, it's there. Framingham study's been known to everybody.
But the doctors aren't looking at homocysteine. They aren't measuring it. And even if it comes back at 9.8 or 10.5, they're not doing anything about it.
Yeah.
Where's the disconnect?
We need to go back and just look at our biochemistry textbooks. That's it. And it's all in the physiology. So you're asking me for my top 10. Homocysteine, because it speaks to what's happening between the free radical and the antioxidant state, right? Number 2, ultra-sensitive CRP. For me, that's not a fad like it's become now. I told you, from 2003, every one of our patients got it. So vitally important. For me, a measure of insulin resistance. I know the HOMA index is not a perfect one, but you cannot do a euglycemic clamp on every patient. You don't have 2 to 4 hours. It's too expensive. And if every metabolic clinical pharmaceutical trial is measuring it, so it's okay for them to measure it, give you the results, and you're happy to look at the results, but you can't use it in your practice. So for me, a measure of insulin resistance, either clinically or biochemically, vitally important. Why for every patient? Because the very gene that kept you alive, insulin, hyperinsulinemia, was protective when food was a scarcity, has come back and bit us in our ass now. That's why the prevalence of obesity and type 2 diabetes is so high. So for me, that is vitally important. Liver, very important. The liver speaks volumes in terms of what's happening. There must be a reason why your maker's given this organ a dual blood supply and no other organ has a dual blood supply. There must be. So vitally important for me. For me, the lipogram is important. Not for the reasons why you might think. The lipogram speaks volumes to me in terms of what's happening with the liver and what the patient's eating. Because sometimes the patient thinks they're eating healthy. But, food has been adulterated. So that speaks volumes in terms of what's happening. You spoke about magnesium, not just serum magnesium, red blood cell magnesium. Magnesium controls or has its finger in over 300 different chemical reactions. How can it not be important? You see, for me, I see a patient in ICU, pheochromocytoma, blood pressure through the roof, about to die. We're not winning. Infuse 4 grams of magnesium. That's a reset button. You're sitting with a patient with preeclampsia. Nothing's working out for this patient. About to deliver. Put on 30 kilos in fluid over the last 3-4 days. Glucose through the roof. Blood pressure through the roof. Bleeding to death. 4 grams of magnesium sulfate and you reboot. And I can say the same about asthma and I can say about status epilepticus. There is something more to this magnesium than we would. So for me, that is important. Of course, I'm an endocrinologist. Based on what they're going to tell me, the adrenal and thyroid, very important. And so, you spoke about ferritin. Every one of our patients has a ferritin back from 2003. Now, I'm not getting the sick patient in ICU, right? So from a functional medicine perspective, that speaks volumes in terms of what's happening with the liver. Too much iron is no good in the system. Too little is no good in the system as well. So there's a few of these tests that are vitally important. They're low-hanging fruits, and I think they're very important. And let me end off by saying vitamin D. Now, there are problems with vitamin D and the way it's measured. But the problem then lies with our tests, not with that molecule. It's a pro-hormone. There must be a reason why most of endocrinology has their receptors with the DNA, whereas all the other multivitamins have their receptors sitting on the cell membrane. Why does this one have direct talk to the DNA? There must be important. So we've misnamed it a vitamin. It's a pro-hormone. It's a building block. And so, just like plants rely on photosynthesis, we know vitamin D has its finger in 2/3 of the genome, 2/3 of the DNA. And I just spoke about its role in the immune system. And it goes beyond bone. So for me, the vitamin D is very important as well.
Great. Let's just quickly unpack vitamin D. How important it is from supplementation to getting it from the sun. It looks like there's a change from cholesterol into vitamin D. So when you get it from the sun, and it seems like we're spending a lot of time indoor, do you think there's a difference between supplementation of looking at maybe a patient with a 50 ng per ml, that supplements to getting 50 ng per ml from the sun?
So there's a lot here, right? So let's just talk about normal levels. This is the only reference range that is completely different to anything else in medicine. If you look at the reference range, it says deficient, insufficient, sufficient. Nowhere else have we described anything in medicine like that. It comes from a very bone-centric approach to the importance of vitamin D. Because in the past, we thought vitamin D was only important for bone, had a role to play with calcium and hormone PTH, and that's where it stopped. And so if you had a level of around 30, with the reference range being anything from 0 to 100, 30 was sufficient. Well, if my kid had to come with a maths mark of 39, I don't think I'll be happy.
Yeah.
And 41 is a pass mark.
Yeah.
So 30 is exactly what it says, sufficient. It never said normal, it never said anything, but we had a bone-centric view to it. Lots of data showing that beyond bone, it has an immunomodulatory property that kicks in when the levels are around 70, and that it plays a metabolic role when it's above 50, and it has a role to play with cancer as well. Of course, it's emerging data. So that's why people are cautious. But for me, and I tell my students this, there's an elegant study. Nature showed you the way. You see, vitamin D3 is made in the sun. Well, all my colleagues are using calciferol. Guess what? That's D2. You still need to go and sit in the sun for it to be converted to D3. Well, if you sat in the sun, you wouldn't have needed the supplement because you would have made your own D3.
Sure.
And so, just last week, I had 3 patients from the same rheumatologist using calciferol and not getting good results. It's not going to change. So, you must supplement. Ideally, you want 40 minutes of sun exposing 40% of your body, morning sun, because we're sitting in above the ozone. And so that would be the ideal. Well, I tried it 2 Decembers ago, pre-COVID. I said, December, slow period, let me try it. Listen, I was struggling to get 15 minutes of morning sun every day. And I was purposefully going out with my trampoline, doing my own thing. You know, I'm a bit ADD and I can't sit there just sitting in the sun. I needed to do something else. But the point was, it was difficult to get. So the next best thing is you have to supplement. So what kind of dosing you're looking at? Well, I would say not D2, D3. Because that way, your patient doesn't have to go in the sun. That was first prize, but they don't need to go in the sun because they're listening to the dermatologist, right? So how much to take? Well, on average, I'm having to use 10,000 units per day for at least 2 to 3 months to get my patient to a good level. Once they're at a good level, at the moment I'm defaulting to 3,000 units. That's the COVID dose. That's the published COVID dose from a protective perspective. So vitamin D has become sexier now since COVID.
Yeah, sure.
Yeah? It's the one thing everybody on the planet agrees to. A year ago, they were not agreeing. Is it allopurinol? Is it an ARV? Is it this drug? Is it that drug? But the one thing they all agreed on is vitamin C, vitamin D. Yeah? Amazing. And then the clotting thing. So it's amazing. But it was always there. Is this new? No, it was always there. We were blindsided to it. So at the moment, 10,000 units for everybody until they get to a good level. The good level is dependent on what their metabolic or the immunological state is. And then I maintain it with 3,000 units.
Fantastic. Let's talk about heart rate variability and sleep, REM sleep, deep sleep, how important it is to measure that, quality sleep. I think heart rate variability of having the sympathetic nervous system and parasympathetic nervous system, is an area of significant dysfunction now in modern living. What do you feel about it?
So you one of my tests was the adrenal function, yeah? And that speaks to DHA and cortisol, the famous duo. The other thing about endocrinology is one needs to understand that nothing is in isolation. Estrogen, progesterone, DHA, cortisol, insulin, glucagon, yin and yang, right? TSH, T4. There's a balance with everything. So I look at DHA and cortisol and look at the ratio as well. Because modern medicine's good. On the one extreme, we've got Edison's and autoimmune condition too low. Above 535, we're looking for Cushing's. And then in between, we're not sure. There's this massive reference range that you were talking about, right? And so there must be something in it. And so from a cortisol perspective, we need to understand, why is it in the system? Why is it even a player? It's a player because for most of mankind's life, we had only two things to worry about. Where the next meal is coming from, you're a hunter and gatherer, and is the next tribe coming to kill you, or is there a saber-cat tooth around the corner that's going to grab you? Finish. Yeah. Flight and fright and getting the calories in. So from a flight and fright perspective, in the past, it was a short transaction. Yeah. The lion ate you. Finish. Game over. Yeah. Or you got up the tree, heart rate went down, you sorted. Yeah. But 10,000 years ago, there was a long winter. Okay, 3 months, 4 months, 5 months. You either did or you survived it. Game over. That was your stressor. Nowadays, I'm stuck behind a taxi. I've got melanoma. I've got news telling me how a 3-year-old was raped. Yeah. I've got kids drop off. I've got a bond to pay. That's just the start. And then you've got Donald Trump, and then you've got this, and then you've got that country, and you're doing this. All these stresses can't be normal. We, over millions of years, were not wired for this. And in the last 100, 200 years, we're sitting with chronic, low-grade stress. And we know cortisol and DHA plays a role with the immune system through TH1 and TH2. Yin and yang. And that's shifting. And that has to have a role in the metabolic pathway. That has to have a role with cancer. That has to have a role with a lot of what you spoke about. So for me, that adrenal is important.
DHA cortisol ratio above 15.
So it's about
20.
So for me, it's about the gender, the age, and what's happening with the patient, right? And so Prof. Dub taught me, everything lies in history. All your diagnosis is with history. The tests just confirm it, and then you go on. And so the examination is important, the tests are important, but most of the answers are lying in the history. And so that's why what ratio may work for you may not be his ratio. Yeah. And so from that perspective, it is very individualized, but at least you understand the concept that there is this ratio, right? Sure. So beyond an absolute number, there's a ratio. And so you spoke about the sympathetic, parasympathetic pathway. Okay, that's how we wired. Because it's the flight and fright, and something needs to calm that system down. But we don't have this calming system down. We're only starting to understand the importance of the vagal nerve. Now let's bring it home. I always say you get diseased, it's a blessing. Because it veers you in the right direction. It points you to say, this is where I need to be looking in my life. Emotionally, from a mindset perspective, from a relationship perspective, from an eating perspective, from an activity perspective, and then just finding your dharma in life, your purpose in life, your job. Okay? And it's all about balance. I've always had a problem with that psoas muscle. And so, about 2 weeks ago, my son was showing me something with the weights. I heard him wrong, and he said you do sets of 21, 7, 7, 7, and I did 3 sets of 21, 21, 21. So I was sitting in the 60s, and I pulled my back muscle. Anyway, so I went to the physio. The physio is working on me. I've been in agony over the last few weeks. Only Aretha knows, right? And I've been hiding it, and so the physio is working on me. And towards the end of the physio sessions, he said, I've got a background in osteopathy as well. Do you mind if I just end up with a bit of osteopathy? And I said, sure. And so what she does, She does what an osteopath would do. It's her hands there, and I'm sitting there. She's doing what she's doing. We're just having a casual chat. Nothing's happening. And all of a sudden, I just feel, wow, this wave in that muscle, and there's a complete relaxation. And I said, God, what happened there? And she said, it's your fascia. I'm used to knots. I go for my massages and breaking the knots. And she said, it's your fascia. That's where you need to work on it. And you see, if you don't experience it, Western trained doctor is going to say, God, this is bullshit. I don't understand this. I don't understand this, right? But it had to happen to me, because after 2 weeks of not getting released, wow, it just released. Okay. Do I know how it works? No. Do I need to understand it? I would love to understand it. By me not understanding it, does it mean it doesn't exist? It exists.
Yeah.
I just don't understand it.
Okay.
Just like 500 years ago, air existed between you and I. However, some people were crucified at the cross for talking about it.
Yeah.
Now that you have an experiment to prove that there's something that exists between you and I that's called air, is it new? No, it was always there. I didn't have an understanding to receive that knowledge. There's a lot in modern medicine. We must just be open to it.
Great.
And along the journey, we'll hit a few bumps. Sure. And I'm not saying experiment on patients. And where you've got big trials, of course, use it. Yeah. I do clinical trials. I do pharmacological clinical trials. We're on trial number 56. We do trials on the new agents in diabetes, hypertension, statins, and all of this stuff. But a lot of physiology and a lot of hormonal work has been done for you already. Yeah. And where you're using a natural system,
good.
Use it to your advantage.
Fantastic. Well, summarize. I want to talk about interventions quickly. I know we're coming to the end of the show, but talk about some meditation, breath work, mindfulness, yoga, trampolining. It sounds rebounding you're doing. What are the sort of very sort of important things that people can do or that you do? Give us your story in terms of treating your health.
So for me, mind is very important. And intellect is very important as well. So although I look Indian and I'm Indian, it was actually a white man who introduced me to meditation in Standard 8.
Okay. So
I went to a boarding school, and Mr. Henry asked, do you guys want to learn meditation? And he was from the hippie age, and he used to meditate. He was in his 50s and he used to meditate every day. And we said, yeah, sure. A few of us picked up our hands, and then he brought in the meditation practitioners at the time, and they taught me how to meditate, and the rest was history. And through my life, I meditated, and I went off it, and I meditated, and I went off it, its phases. I've always known about yoga, but I was introduced to yoga at age 33.
Okay, let's stop your yoga journey. Tell us about your meditation practice. Is it TCM? What do you do, and how often do you do it?
The induction was through TM.
Okay.
Because that's where he learned it, right? Yeah. But my journey was a bit of a different one. And so the technique, I think, doesn't matter. I think it's the repetition and mastering it and getting your 10,000 hours.
Okay.
And it's about stilling the mind, getting it out of the equation, and then being in that emptiness.
Okay.
And we are just empty. I mean, if you go down to a cellular level, you go down to an atom, it's mainly all emptiness, isn't it? And so from that perspective, I've had a long relationship with an organization called Divine Life Society in America. It's all over the world. But in India, I go off to the Himalayas once a year towards the end of the year. Last 2 years have been a vacuum for obvious reasons. But and a great master there told me, who unfortunately passed on, but him and I had a relationship for over 20 years. And he said he left this plane of life about 1.5 years ago, and he told me, you are not going to find your maker in the caves of the Himalayas. Go back and find it in your work. And so he sent me off marching, because at age 39 I requested for me to come and my wife and I to go and live there, and there's a hospital with the ashram and to work there. But anyway, he sent me marching. 15 years I'm still here. And so I think it doesn't matter what you call meditation. Just start.
Okay.
My advice to everybody is just start somewhere. Just go into the quietness. And meditation is not a religious practice. Why do you think when you go to the cathedrals, there's quiet space? That Buddha is the medicine Buddha was given to me by a monk, Catholic monk living in the Himalayas, and he gave me that Buddha with that Catholic rosary. And so what do you think the rosary is there for? Is to bring your attention, focus it to one space. The Chinese teach the same thing. The Buddhists teach the same thing. The Sufis in Islam, the Hindus talk about it. It's just about silence. So I would say just anybody, start with silence and it will take you on an exciting journey. And the person who might introduce it to you or show you how to master the technique is just your teacher.
Okay.
So for me, meditation is a personal thing. Okay. It's time out. It's the silence. And
you do breath work with it. You do specific breathing
so meditation,
techniques.
The next step, the start to the silence. You realize that you're not going to get anywhere until you have control over the breath. And so once you have control over the breath, then you have control over the sympathetic and parasympathetic pathway. And it's all about calming that system down. And so it's called pranayama. So the yoga system described by the ancients is a 7-system pathway. As a Westerner, you're calling yoga what they used to call asanas. Asanas are postures. That was only one part of yoga, but there's 6 other parts. The other part is pranayama. It's the breath work. There's the meditation. There's the dietary aspect of it. There's all so yoga is actually a composite of 7 different things. One of it being the postures that we talk about. So breathing is the next step that comes with the meditation, and breathing is very important. Breath work, difficult to master. I'm far from it, but I know the importance of it. And so for me, exercise is important as well. So I'm an avid trainer. For the last 2 weeks I haven't, but I'm up at 4 in the morning. I train from 4 to 5. I've got a series of things that I do, and as you get older you adapt it. I haven't done karate for 2 years because of COVID, but thanks to my boy, we started karate when he was 5 and I was 45, and that was a nice discipline as well. So and he does boxing now, so we do a bit of everything, but it's about trying to find balance. Eating is very important. I was fortunate enough to be born vegetarian. I don't think that is the way for everybody. It's very difficult, but it was easy because I was born into it. And so eating right has been easy. And I follow the philosophy of 1 day cheat, 6 days belongs to the doctor. Okay. And so we have a cheat day, and it's a way of life. I was just telling a patient yesterday, my boys and I with my wife go to a restaurant, and 9 out of 10 my boys will choose water. And sometimes I have to tell them, well, just have a choose today, or just have a cool drink. And they have the cheat days, and my boys eat rye bread. Why? Because they don't know any better. Because they were born. They seen their parents do this, and so it's become the norm. And so it's about finding balance. So I think the mind's important, meditation's important, breath work's important, eating right's important, being active is important, trying to find balance between family life and work. But I think what's very important is that most of us are wired to be active. What we call work or vocation is called dharma in my practice. Dharma means purpose. Once one understands what purpose means, is that we all have a divine purpose. And that means you're an instrument. You're not a doer. And once you realize you're not a doer, then you're a vehicle. Then all else will just hopefully come right.
Fantastic. We've got this little acronym at Made to Thrive, TGIM. Thank God it's Monday. To swing it from TGIF. People are waiting for weekends, they're waiting for holidays, they don't realize work's a blessing. And as you said, you're a conduit to healing, to blessing, being in the medical profession. So thank you so much. The last thing is speaking to a social scientist. He said that the number 1 predictor on longevity is social ties and social integration. Tell us a little bit about how important relationships are in your social ties and that.
you know, in the last 18 to 19 months, I've come full circle as well. And I've realized the importance of psychotherapy and the psychologist. And I've realized the importance of the first 6 years in one's life, where you react from the reptilian brain to every stimulus in an environment for your survival, to grab your parents' attention, to get the attention of the caregiver. And then the rest of your life, you're trying to heal that. And so relationship is very important. And I'm fortunate to be married to one of the most fantastic human beings on this planet. And God knows, now I know she's been trying so long for me to work on certain aspects and a lot. And it's a journey. And it's a journey. And I don't think the journey is ever over. And so I think from that part, relationships matter. The relationship you have with your mother, the relationship you have with your father, the relationship you have with your friend, your wife especially, or your partner, your life partner, your children, your siblings. And actually I've seen it in my work as well. Then I think I'm a bit of a different teacher now than I was 18 months ago, and I'm a different doctor or caregiver than I was 18 months ago as well. And so it's a journey, and I think relationships are very important because they feed the soul.
Fantastic. We're coming to the end of the show. I'd really like you just to leave one little bit of pearl of wisdom with the audience. If they can do something today or something tomorrow, what is the one thing that you would like people to attribute with Dr. Bhana, who's got an incredible legacy, and it's an honor and privilege to know you. And like I said from the beginning, you've treated thousands of patients, and you've lectured, and you've educated, and you're a humble man who wants to see people living the life that they were called to live. So what is the one thing that you want to leave with the audience?
My philosophy in life is be fearless, and everybody who's worked with me will tell you, don't use the word I can't. If somebody's been on the moon, you can get to the moon. If somebody's made a Boeing 747, you have the capabilities of it. You've got the same DNA. You've got the same mind. And if somebody's got a farm and they're the best tomato producers in the world, which is my passion, farming, you can do that as well. And so trust in yourself. And the journey starts now, not tomorrow. Make the change today. And if you change, Gandhi said that, everything else will follow. And so if you make the change with your mind, with your breathing, with your eating, with your activity, with your health, then the world's your oyster. Because on this desk, I've treated rich and poor. I've had people offer me things you will not believe to buy the health back. And sometimes it's too late. And the body is an amazing organ. It's so forgiving up to a point. Once you cross that point, it's difficult. And so my thing is, be fearless. Never say I can't with anything, whether it's your matric exam or with growing something that is impossible. I know somebody told me you can't grow lychees and mangoes in Johannesburg.
You've done it.
It's not I've done it. I'm just saying it can be done. No. I have done it, but it's not about the ego. I know. It's not about the challenge.
Thank you so much. I look forward to part 2. It's taken me, I think, about a year to get you on, but I've got, Dr. Manga on here, and Dr. Ibrahim here, and Dr. Matara, these people that are your friends that you've worked with for a long time. So I really appreciate it. And I look forward to changing many people's lives together. Thank you so much.
Keep up the good work.